Happy Monday. My name is Rob. I'm here to tell you about hereditary and young-onset colorectal cancer, and I'm not a colorectal surgeon, but nor do I see any colorectal surgeons here, so I get to speak from a position of complete authority. So first, these are topics that, much like I think the last talk I gave, they're ripe with ABSITE fodder, but in real life, you are unlikely to see many of these patients. Patients with FAP, which we're going to talk a lot about, they have these giant nationwide registries to follow these patients. And like in Scandinavia, for example, in Utah, where they take really detailed family history records and stuff like that. And in Utah, which is one of the better maintained registries, they have like 120 patients in it. So it's not like this is a very common thing. We will talk a lot about Lynch syndrome because Lynch syndrome is common enough that you're going to see it day in and day out, especially if you go into a surgery career. And then there's some other weird things like Poitieres and juvenile polyposis that you need to know about, again, for testing purposes. But if you see them in your real life, it's probably because you're at like a quaternary referral center for such patients. So keep them in mind, but we're not going to go too much on that. Second, this is the thing that scares me, and just a little plug for y'all getting scared too. Young onset colorectal cancer, that's people getting diagnosed, treated for colon cancer before the age of 50 in some registries, 40 in others, is on the rise in this country for reasons we don't understand. So this is predominantly left-sided tumors, predominantly sigmoid and rectal cancers. It came to the point where one of my co-fellows, when I was in fellowship, ended up getting a colonoscopy. He just got so freaked out by all these young people with metastatic rectal cancer that we were treating. I lost count of how many 30-year-olds that we treated with rectal cancers. This will be available for you later, but anyway, so like this is gonna be the brass tacks of this talk. We'll make this available for you as a PDF, so for your ABSITE studying. There's a lot of stuff that goes on, and so like one of the bigger teaching points I think of this is we're surgeons. Do we operate on genes? Can I cut out APC? Can I cut out MSH2 or 6? No. What we have to do is be aware that these things exist and be aware that at least for some of these things, there are treatment implications for them. I'm definitely not going to talk about Poitieres. I'm definitely not going to talk about juvenile polyposis. Their data are there for your review later. Whoops. Well, we're also not going to talk about P10 hematoma, also called Cowden syndrome. This shows up on test every year, but basically you get hematomas in all three germ cell layers: CNS, skin, breast, thyroid, GI tract. So think about that. If someone comes in with hematomatous looking changes like polypoid lesions all over their body, including like on their tongue, and the thyroid tumor, breast cancer, and they have colorectal polyps. Oh, Cowden syndrome. Hey, can I operate on P10? No. Okay, cool. So that's enough about that. And the other one is Banayan-Riley-Ruvalcaba syndrome. And yeah, it's fun because like, what is it? Hemophagocytic lymphohistiocytosis. It's something that people just like to say. Nobody has an idea what it is because it's really rare and can't really do anything about it. So there's that. So we're going to talk about these three things. Briefly, the history, then the molecular genetics, which is where at least I can speak with a little bit of authority over our colorectal surgeons, and then clinical management, where I can speak with no authority over our colorectal surgeons. So you'll get us in my level of comfort going down. So first, we've known about these things for a long time. So in 1860s, Lebert and Richet described patients with polyposis in Europe. And so it's our first kind of clue that, hey, there are these people whose colons are getting carpeted with polyps. In 1913, Aldred Warthin publishes the family G pedigree. That came from his seamstress, who told him, he was a pathologist, who told him she was nervous because everybody in her family died of cancer. Women with colon cancer, endometrial cancer, stomach cancers, and stuff like that. He said, that's really weird. So he abandoned his work as a pathologist and went into mostly genetics kind of background, took detailed family history. And this family G, is kind of the start of what we think of hereditary non-polyposis colorectal syndrome. Bonus facts, Sheckman, where was Warthin? I'm choosing you for a reason. Ukraine? University of Michigan. Warthin. Of Warthin's tumor fame. Anyway, for our world, he's far more popular and famous because he described Lynch syndrome. He was one of the first. In 1924, in England, Dr. Lockhart Mummery, who was called, I don't know if I would like this term, King Rectum, describes an autosomal dominant FAP inheritance and establishes the first polyposis registry in London at the time. King Rectum. I don't know if that's like, if he earned that or if he wanted that, I'm not sure. 1966, Dr. Lynch publishes a larger family series in Nebraska. These are families N and M. In 1991, we found out that truncating APC mutations were found to cause most familial adenomatous polyposis. In 1993, we discovered mismatched repair genes. I think the first one was MLH1 and then MSH2. And in 2000, they went back to family G's pedigree and did some kind of crazy science stuff and found out that family G had a germline mutation in MSH2, confirming the diagnosis. They were the first well-described family with Lynch syndrome. So that's about history. Know your history. Molecular genetics. Okay, ABSITE questions. First, for interns. Surgery interns. Neelan. Is Neelan here? Neelan. APC is an early mutation in sporadic colorectal cancer. True or false? Krill ABSITE questions are generally true, false. True. Excellent. Turns out it's one of the earliest genetic events that gets triggered in this colorectal adenoma-carcinoma sequence. This is something that you can get offline, but if you type in adenoma-carcinoma sequence, it was first described for colorectal cancer by this guy, Vogelstein, I think, reported in New England Journal of Medicine a long time ago. It has undergone many iterations and modifications, but the basics stay the same. We think normal colon mucosa takes a genetic hit, turns into hyperplastic mucosa. One of those early hits is probably an APC. And then as it goes along, it collects more genetic hits, such like signaling, so that's APC, such like KRAS, which is a cancer signaling cascade mutation, which accumulates more. And then down the road, they get these bigger hits, like this one, DCC, fun stuff. Ellie, what does DCC stand for? Stands for deleted in colon cancer, because we have a hard time with gene names. The reason this is one of the most common genetic mutations that is discovered in all colon cancers, but it's a relatively late event. It happens on chromosome 18. They talk about chromosome 18 loss of heterozygosity. It's that gene deleted in colon cancer. Is it actionable? No, it's just fun trivia stuff. And then P53 loss, once things start really getting nasty from advanced adenomas, dysplasia to frank cancer. All the while underpinning all of this, which this was, I think, in an earlier iteration of the Vogelgram, MLH1, MSH2, so mismatch repair. So these underlying cell protective mechanisms like mismatch repair, if they're intact, it tries to fight off some of these progressive genetic hits. If they're not intact, like in Lynch syndrome, you'll find these things tend to spiral really quickly. So as we go along, this is way oversimplified. You can see at the top, this is how long we think it takes. It takes years to decades to go from epithelium to adenoma, and then another 5 to 10 years to go from adenoma to carcinoma. Again, we know that this is not necessarily the case in all patients now. Second, signaling pathways, you can't escape them. So one that is very common is the RAS-RAF-MEK, or the MAP kinase pathway described on the left of this slide. So something hits epidermal growth factor receptor, which is a transmembrane receptor that starts this signaling cascade. Things get phosphorylated, turned on, turned off, on and on and on and on, down to angiogenesis, invasion, cell survival, and cell proliferation. What's important about this pathway, particularly for colorectal cancer, particularly for this talk, is that each of these steps, EGFR, RAS, RAF, and MEK, now have FDA-approved drugs. So when patients have constitutive problems with one of these, we have targetable actions. Or if they have a cancer with one of these mutations identified, we have targetable things. There are drugs, in fact, for the right side of that as well, just none of them have been FDA approved for metastatic colorectal cancer yet. So we're gonna stick on the left side of this for the purposes of this talk. All right, next, Tess. Germline mutations are the most common onset of young-onset colorectal cancer. Just been through all these genes, all these signaling cascades. Now let's just go back, bring it back to the clinical world. Germline mutations, so someone with an inherited cancer predisposition, are the most common causes of young-onset colon cancer. False. This is the scary thing again about young-onset colon cancer. One, we don't screen for it, right? Dr. Clifton gave this great talk about screening yesterday, and we want to institute surveillance for cancers at an age where we think early intervention is going to change that trajectory of the course. These are patients who get their cancer and get metastatic cancer before we would even start screening for it. Only about 10% or less have a recognized hereditary syndrome, which goes with national trends. 5% of colon cancers have some kind of heritable component to it. You see a slight enrichment of that in the young onset colon cancers, predominantly because of FAP, but remember, FAP is rare, so you're not going to see more of that. They're more likely to be MSI high, but again, that's as a more likely than sporadic cancers. Doesn't mean that they're going to be, the majority of them are going to have that. And they're more commonly left-sided. So again, what we think of these Lynch syndromes, cancers tend to be on the right side. Young onset colorectal cancer is still a left-sided phenomenon. Yes, Olivia. Sometimes before, yeah. These patients almost all get picked up by symptoms, and symptoms are pain, rectal bleeding. And yeah, so anyway, this is the freaky part of it. I'm sorry. So on the histogram on the right are mutation spectrums. This is from Memorial on young versus average onset colorectal cancer. And the reason the print is tiny is because you don't really need to know the genes. What's more important is you see the red bars and the blue bars, how they're basically the same size. So we're saying we haven't identified a smoking gun gene mutation that is driving young onset colon cancer. I think this is among the last of the basic science things for you. Genotype-phenotype. So depending on where you get the mutation determines what clinical manifestations you have. Of import, here is the bottom, where you can get severe desmoid disease, and we'll talk about desmoids later. But those are 3' ends, so one end of the gene. If they have truncating mutations near that end, their patients with those pedigrees have far more commonly desmoid disease than other extra abdominal manifestations. And then another, we know so much about cancer, yay. So mismatch repair, where that falls in. This, what I want you to focus on is the entire slide saying like there's a lot of stuff that the body does to keep things in check because DNA replication is not a high fidelity process, but we have enough redundancy in these systems to fix those problems that it can be okay until we have a problem with like homologous recombination with BRCA, and that leads to people getting certain cancers. And for the purposes of this talk, again, base match mispair. So single base insertion, whoops, didn't do it right. Let's figure it out. Let's cut it out. If that process is broken, this leads to hypermutation of cancer cells, eventually neoantigen expression as well, which is why they respond to immune therapy. Top right, those 4 things, MLH1, MSH2, PMS2, and MSH6, those are the most likely culprits for it. And then this new thing, EpCAM, which is basically, it facilitates MSH2. So just like PALB2 facilitates BRCA, EpCAM facilitates MSH. And so if you have an EpCAM mutation, you can have a phenotype like MSI high, like Lynch syndrome. The same as if you have a PALB mutation, you have a phenotype like a BRCA mutation. Sweet, mismatch repair deficiency. So these do have clinical correlates. This is a histogram of mutation profiles based on primary tumor location in one of these giant colon cancer trials. What they found is the left side of the screen. So patients with proximal tumors, so appendix to transverse colon, are far more likely to have BRAF and MMR deficient tumors. But if you look across it, KRAS is still the dominant type. So if you're doing like, if you're going to hang your money on what is most likely mutated, KRAS still wins out. But if you have a right-sided tumor, far more likely to have either MMR protein deficiency or BRAF mutation. And so that's why when we were talking about that guy that came in, the 80-year-old with a new colon cancer on the right side that like progressed really rapidly, I was like, I bet he's BRAF. It's because of this thing. It's not because I'm smart. Okay. So enough of that. Clinical management. To intervene on these patients, you need to know how the disease goes. You need to know whether we can screen for it, how we can prevent it, and how to treat it. I'm going to not talk too much about the treatment because we have colorectal surgeons who can wax way more eloquently than I can about the pros and cons of different surgical approaches. But we can talk a lot more about natural history and screening, particularly as it relates to the cancer side of things. So for FAP, colorectal adenomas developed by puberty. Most of them have, in the severe forms, most of them will have hundreds of adenomas by the time they get their first colonoscopy in their teens. Suck. Symptoms, bleeding, pain, obstruction in their 30s. This is untreated. Colon cancer by age 40, median. 100% of patients, if left untreated, will get colon cancer. Duodenal cancer in up to 10% of these patients, and that will typically crop up by median age of 50. And then desmoids and other manifestations based on the mutation site, like you saw in the earlier slide. However, now that we're screening for these patients, we keep them in family registries. Colorectal cause is no longer the leading cause of death. So this is the Utah FAP registry, where they looked at death causes over the last decade and a half. Turns out the gastric cancer, the proximal GI tract cancers are starting to take over now that we are doing preventive colectomy in these patients. And desmoid tumors as well. So that's, we'll go into that a little bit more, but I understand desmoid tumor, while not a cancer, is a big problem. Colorectal cancer, not so much. They have just as many deaths by, this is the sad part, just as many deaths by suicide in these registries now. Now that these people know they're getting so worked up over diagnosis and over medical care over it that it's really introducing a lot of toxicity in their lives. Very sad stuff. Lynch syndrome, different. Colorectal adenoma is developed by age 50, which is generally what we see in the population, a little bit earlier. Once the adenomas develop, however, they progress to cancer much faster. So remember that slide where I said we thought it took about 10 to 20 years to go from normal colon epithelium to cancer? In the Lynch model, we think it generally takes about 3 years once the adenoma pops up that it can evolve into a cancer. 7 to 10 years is sporadic. Endometrial cancer, this is for boards and for real life, is the most common non-colorectal tumor. That doesn't change how we manage these patients. And other cancers, and there's tons of them, will pop up sporadically depending on family history, depending on which gene is mutated, and depending on how old the patient lives. So screening, so that's natural history. That's if we don't intervene. So now we have to start talking about where we intervene. For FAP, we start colonoscopies in puberty, basically like 10 to 12, depending on the guidelines, you read anywhere from 10 to 12 years. EGD, because they get duodenal polyposis, starting in their mid-20s. Think about desmoids based on their family history. There's no screening test for it. So depending on where you practice, some people will get abdominal imaging, particularly once they're considering surgery to see where that goes. And then thyroid cancers, because they can get papillary thyroid cancers. Palpate the thyroid when you're doing your exam. Some guidelines say get ultrasounds. There's really no data that screening for thyroid cancer in FAP patients will decrease their chances of dying from papillary thyroid cancer. Based on your earlier talk, does papillary thyroid cancer kill anybody with FAP, do you think? Okay, cool. So duodenal polyposis, this will probably come up in your testing. And the reason why we talk about this, we don't do Whipples on everybody, right? We don't do duodenectomies on everybody with FAP. There is a scoring system. It's based on Dr. Spiegelman, and I don't know where he was from. But so basically, the more polyps you have, the bigger the polyps you have, and the more dysplasia there is, the more severe their stage. The reason this comes into play is right here. So it goes on a 0. So they use these things to calculate a score. That score is used to derive a stage from 0 to 4. And 0 to 4 can tell you what their projected probability of having a cancer is on an X-plane. So the one you really need to know about is 3 and 4. That's 3 and 4 where they start to have an uptick in their cancer prevalence, and when these patients are subject to surgery, particularly stage 4. That's for people with large tumors, or sorry, large adenomas, lots of them. Some of them have dysplasia. And that's when we should start thinking about surgery. The problem is, you can tell there the cancer prevalence goes 0, 0, 2 to 40%. So this isn't a very specific, it's not a very specific scoring system for this thing. So there's a lot of judgment that goes into it, which is why there are specialty centers for these patients. Chemo prevention, and we'll talk about in a second, that's like aspirin, Cilindac. Screening for Lynch syndrome, historical interest. I don't know if it's still coming up on tests. I hope not. Amsterdam 2 criteria, 3-2-1 rule, 3 relatives. With Lynch cancers, one should be a first-degree relative of the other 2. 2 successive generations affected. 1 relative diagnosed before age 50. And there's this revised Bethesda criteria for tumor testing. So this was before 2018, 2015, 2016. Since 2016, everybody gets MMR protein expression testing. That made its way into the NCCN guidelines, I think, in 2018. And if they have deficient MMR protein expression, that prompts further testing for either germline mismatch repair genes or for BRAF mutation. And we'll go into which ones we do in a little bit. So I don't know if they're still testing this. Does anybody know if they're still testing this? Yeah. So the problem with it is, okay, so listen, what proportion of people meeting Amsterdam criteria had a germline mismatch repair?
I think it's very insensitive. 60%.
Yeah. Yeah. And there are people, they're full-blown Amsterdam, like popping positive, that have no identifiable mutation. 40% of them will as well. So it's not very sensitive. It is helpful though. I mean, these are patients that can be managed like Lynch patients if you want to, but it's not going to say like, oh, this is Lynch. Trivia time. Okay. Let's kick it back. Here, fourth. Cat Thomas. Colorectal polyposis and brain tumors. Sweet. Oh, cat bonus. Is Turcotte related to FAP or Lynch? Boom, knocked it out. Sweet. So they just had to have some kind of polyps. Yeah, totally trivia. Can we operate it? It doesn't matter, right? Okay, cool. Okay, so if you're doing your colonoscopies, Spencer, and you see 10 or more adenomas, that reflexes you down this pathway towards what? Yeah, you're working up for FAP. That's about it. Okay, you see 2 hamartomatous polyps, and I don't really know what they look like. I've never seen one myself, but there's pictures of them online. Maybe, but far more like, yeah, Poitz-Jeghers. So any of the hamartoma syndromes, Poitz-Jeghers, juvenile polyposis, or Cadden-Petian hamartoma. Which stinks for them because then there's like a big like genetic screening thing for them again. Like these have lots of other manifestations and stuff like that. Okay, Olivia. Mismatch repair testing shows loss of MLH1. Is it Lynch? Yes and no. So Lynch or BRAF mutation. So those patients get reflex BRAF testing as well, depending on their age. And Bobby, why is that? Yeah. So BRAF mutations lead to a Lynch phenotype. So in both situations, MLH1 is knocked out. The difference is in Lynch syndrome, there's a germline mutation in MLH1 that means it doesn't work. In BRAF, the BRAF mutation product leads to methylation of the MLH1 promoter region, which inactivates the gene. So both of them get a Lynch phenotype. One of them is Lynch syndrome. Sweet. So prevention implications. I don't see Phil here. Phil Kent-Bohan wrote an excellent article on this that just got published this year. Props to Phil. So we can use NSAIDs to chemoprophylax for adenoma progression, and we think development in patients with FAP. Reason is adenomas constitutively express higher COX-2 levels than normal epithelium. So you do a COX-2 inhibitor, kind of tamps that down. Unfortunately, and it's been shown again and again and again that they will decrease adenoma burden and size, but they will not 100% prevent dysplasia progression. The most recent randomized trial reported just last year in New England Journal, where they randomized people to Solindac and Solindac plus something that inhibits the, I think, ornithine transferase or something like that. Anyway, so they Solindac versus Solindac and something else. And what they showed was freedom from dysplasia or procedure for polyposis. So either colectomy, Whipple, stuff like that, about half. 50% of patients will still undergoing those kind of things at about 2 years. So it can stave off, but you cannot hang your hat on that it's going to prevent completely. There is no magic bullet yet for FAP. Yeah. And I think so part of it's like risk benefits, and the guidelines tend to hedge on this a lot, depending on which one you're either like, yeah, they should talk about it based on risk benefits with the patient. The downside to Solindac is pretty minor compared to a massive operation. It's just not going to completely prevent it. The same thing with like aspirin. So we talk about, there's a wealth of data that shows that aspirin reduces colorectal cancer recurrence. And so a lot of people that have had a colorectal cancer will get put on 81 to 325 of aspirin just for that reason. The degree to which the absolute risk reduction, though, is a little bit hard to measure because they're old, they'll be on aspirin anyway, all those kind of things. So does it hurt? Probably not, but you got to make sure you're not going to give them renal hypertension, GI bleeding and stuff like that, because that also carries a cost. So not opposed, just saying like it's not a magic bullet. Okay, Surgery. Now this is where I'm I have the least expertise. So for FAP, if they have colorectal cancer, that's easier. If they're high risk for colorectal cancer, if they have a giant, if they have dysplasia, symptoms, failure, you can't monitor them much longer. Gold standard answer is still total proctocolectomy with or without an ileoanal pouch. On the right side of the screen, this is how they construct a J pouch. You take a loop of intestine after you've taken out the colon, you staple it to itself using an interotomy on the other side, and then you take that interotomy and you plug it into the anal transition zone. This remains kind of the guideline recommendation across guideline organizations. Particularly, people have a large rectal polyp burden. The concern is whether you can safely leave the rectum behind. The other alternative is a total abdominal colectomy with an ileorectal anastomosis. And those patients do have a demonstrable increase in rectal cancer formation because they have a rectum, because it gets polyps, and those polyps turn into cancer. And they have to undergo reoperation occasionally for rectal cancer. So if they have baseline bad rectal disease, typically they get the total proctocolectomy. Lap versus open, it's been studied. Guess what? Like every other surgical trial, it doesn't matter as long as you're good at what you do. Rectal sparing considerations, typically if they have low rectal polyp burden, and we're talking like these are people that can faithfully undergo surveillance and faithfully get their rectal polyp scooped out by a gastroenterologist, ileorectal anastomosis is a consideration in them. And then Solendac as well, right? So if you kind of hit them with multimodal therapy, they can keep their rectum, which I think it's a big deal, right? Losing a rectum is a huge thing for every patient, not just us. Nuance comes in the timing. So in people with a strong family history of desmoids, most guideline organizations say wait a little bit. Why is that, Slater? I think I would flip it the other way. So you're going to cause a desmoid. So people think the surgery can lead to desmoid formation in these people. And how do we treat intra-abdominal desmoids? It's all terribly morbid, and it causes downstream things like ureteral obstruction and kidney failure from that. These are infiltrative tumors that are really tough to take out. Total enterectomy, small bowel transplant, they don't have a good answer. And so the thought is you actually just want to stave that off as long as you can to see if you can maybe win the game and they don't get a desmoid after your surgery. For people desiring fertility, it's complicated. Kind of the stock answer is stay out of the pelvis, particularly in a young woman. And remember, these are people that you're counseling on surgery like when they're like teens. So like it's a really task to be like, hey, what do you think? What are your thoughts on fertility to a woman who has probably not thinking about that at all? But some people have really strong feelings about that. And if that's the case, you try to say stay out of the pelvis. It's all based on one survey study in Scandinavia where they compared women who had undergone total procto with a pouch versus ileorectal anastomosis. So women who got the entire thing versus women who we stayed out of the pelvis. And there was about a 50%, they called it decrease in fecundity because it's Scandinavia. And then women who had pelvic operations, which was slightly better than women who were undergoing operations for ulcerative colitis. Don't know why that is, but basically that was about 20 years ago now. And so I think the data should be taken with a huge grain of salt in that. Just keep in mind, like, so if it's someone that fertility is a really important thing to them, then consider, and they're the right patient that you can spare the rectum, consider sparing the rectum. That's what most of the guideline organizations would say. Okay, Thomas, during a planned colectomy for FAP, you encounter an ugly looking mesenteric desmoid. Yeah, it's in the usual spot. Stop. Just... Okay. What would you do about the rectum? Yeah, that's a safe answer. And this is like there's when we have Elliot and then back, we'll have to ask him about this. I can tell you that the Camerons and again the guideline organizations would say do the total procto. The reason being, like, this is your only chance to get in there. That desmoid's probably not getting better. And so you're unlikely to have a good time going back in to finish the job if they get a rectal cancer. So if you see a desmoid in there, and this is why many of our surgeons will get baseline abdominal imaging to see if there are signs of abdominal desmoid before they undertake these operations, because they don't want to get surprised by this kind of a thing. Let's see. Okay, yeah. So let's talk about desmoids real quick.
You also ever, or have you ever come across a recommendation at that time to not do any type of pouch as opposed to an
I think it's a little up in the air, but my impression is that it totally depends on whether you can get the pouch in the pelvis. And so if the desmoid is limiting your mobility, so remember, this is when we take superior mesenteric vessels and we stretch them down into the pelvis to make this pouch. If the desmoid, which is like a giant scar tissue tumor, prevents that from going on, then they're kind of committed to ileostomy or a cock pouch. And so that was why many people historically would undergo cock pouches, because they thought that was a safer, less morbid option than stretching something down in the pelvis. Mm-hmm. Yeah. Now we have some data. So desmoids are also called aggressive fibromatosis. They are soft tissue scar tumors, which we don't understand very well. They're not cancer in that they don't metastasize, but they cause a lot of local problems. They grow, they invade, they can erode into the bowel, and then they can cause bowel obstructions, both from mesenteric retraction and from local mass effect. So in FAP, they're particularly challenging because many of them occur intra-abdominally in the mesentery, as opposed to sporadic desmoids, which can occur basically anywhere that you have soft tissue, so your whole body. A lot of them will occur in the abdominal wall, and that's a different story here. So we're going to be talking specifically about mesenteric desmoids. Abdominal wall desmoids, you have lots of treatment options. You can just cut them out. You can cryoablate them. You can treat them with external beam radiation, which I wouldn't, but you can. And you can consider using systemic therapy. Let's see, someone's on D team. Lexi, systemic therapy for desmoid. What is the only level 1 data we have? It's a drug called sorafenib. So it's a tyrosine kinase inhibitor, and we don't know why it works, but it works. And the only randomized trial of sorafenib, drug versus placebo, people with unresectable, like mesenteric desmoids, were randomized to sorafenib to placebo. And what we found was that the response rate, so tumor shrunk in about 30% of patients on sorafenib. Here's the kicker, 20% in patients on placebo. So it shows that we don't understand much about these tumors. And then how you treat the unresectable ones. So if they progress on sorafenib, then what? This was changing as I was going through fellowship. Our typical approach, at least at Memorial, was to put them on a pegylated doxorubicin called Doxol. So basically sarcoma chemotherapy, but like the easier to take sarcoma chemotherapy, and hope for the best. But you can only get so much of that because, let's see who else is on service. Sorry, send us. What is the dose limiting toxicity of doxorubicin? Yeah, heart failure, right? So you can't treat these young people forever with doxorubicin if they have a progressive desmoid. This is a huge problem. I mean, there is not much. You can try taking it out, but that's when we start talking about like small bowel transplant, because if it's invading their small bowel vasculature, the only way to get margin on it is to take the small bowel vasculature. It's not a good, that's a really tough sell for anybody, including the surgeon. So that's why many people, like I said, many people will get imaging on patients before their colectomy, just so they don't run into the situation where they encounter a desmoid they weren't expecting. And if you see one while you're there, I guess the company line is to do the big operation, because you're not probably going to get another chance to go back in there safely. Okay, so now they made it through their colectomy. Hooray, high fives. Now they got duodenal cancer, which about 10%, right? This is the leading cause of death now, upper GI tract cancers in these patients in the registries. So you have a couple different options. So how these patients will typically present, at least in my experience, is like they keep undergoing kind of shuckouts. They get an EGD, and they get like snare polypectomies and endoscopic mucosal dissections and all this stuff to kind of clean out their duodenum. And then they get another endoscopy in a year and a half, and they got polyps coming back. And eventually the endoscopist like, I can't get this thing out anymore with endoscopy. Can you help? And you're like, great, I hate my life. So you have a couple options. One, if it's not frank cancer, you can consider doing the pancreas sparing duodenectomy, the oft talked about, like almost never done pancreas preserving duodenectomy. This is a description of it right here. So left side, they've done a duodenotomy to make sure that there wasn't frank invasion and they couldn't feel anything. And then you slowly separate the duodenum from the head of the pancreas. And you can do that just with a ligature device. You just make a little window, divide those little tiny perforating vessels up to the ampulla. And then once you get to the ampulla, you have to make a decision what to do. And you basically just cut across it with a knife. And you are left with picture B, which you have two orifices. You got your bile duct and your pancreas duct just kind of sitting there, flopping in the breeze. So they put in some tacking sutures to keep them open. Sometimes they synostose them, meaning they put a this is funny describing a procedure over here going to do, but they tag this thing right here because otherwise this is just flopping in the breeze. And so you just want them to stay there. Sometimes they synostose these because these are both tiny, right? So if you're doing, what do you expect the pancreas duct to look like in a duodenal adenoma resection? Like tiny. It's like the worst whipple. We hate these whipples because it's a tiny duct. It's probably a soft gland because they're young, healthy people. Not good for the. So you do everything you can to make sure that these things are open. Then they put catheters in both of them, and then they swing up a reel in and do some kind of weird jejunal thing. And then they put T-tubes and drains everywhere. Like I said, oft talked about, I've never seen one of these because it's a terrible operation. The alternative, however, is a Whipple, which has a super high risk of leak. So choose your poison, right? Doing a Whipple after someone's had a pouch procedure is also really freaking terrible because that superior mesenteric vein, which we use to do the most of our dissection and divide the pancreas, is on stretch and is scarred down from their prior operation. So these patients need specialty care. Like this is not like your, oh, let's just add on the Whipple at BAMSI kind of case. So there's that. Good news is only about 10% of patients get duodenal cancer from this. They usually die from something else. Okay, now that's FAP. So that's the long and short of it. They need their whole colon out, which is great. Now that people are in registries, now that people are undergoing preventive surgery, their 100% colorectal cancer mortality has since decreased to like less than 10%. Whereas other stuff like desmoid disease, like proximal GI tract cancers, is increasing in prevalence of causes of death. So we haven't won the game. We're getting better though. Lynch syndrome, totally different. You're going to encounter this. Patients, about 5% of our patients, we do 100 of these operations a year, so about 5 of our patients at least per year here will have a mismatch repair deficient tumor. So it's important for us to know about. So in terms of people that are coming to us with a cancer, and we don't know whether they have Lynch syndrome, that situation's easy. Just treat the cancer and we'll figure it out on the back end, right? You're not going to do a total colectomy on everybody that comes with a colon cancer because 5% of them, just because 5% of them may have Lynch syndrome. It's not good medicine. If you know they have Lynch syndrome and then they develop a cancer, that's when it gets complicated. Because it depends not just on the cancer you're treating, it's the cancer you want to prevent down the road, right? In particular, people with MLH1 and MSH2 mutations, those seem to have the highest cancer risk of the Lynch syndrome genes. So the Lynch syndrome the cancer prevalence in MLH1, MSH2 is up to about 70%, and the metachronous cancer, so cancer after they get a segmental colectomy, can be as high as 40% in those patients. So that's when you have to have the long talk about, do we do a total? Do we do a segmental with increased surveillance? And what's it worth both to the patient and to you? Kind of the gold standard, like the society guidelines know, if it's a known Lynch patient that gets a colon cancer, kind of the default should be total colectomy, but there's a lot of wiggle room in that. It's not a strong recommendation for many of them. So there's that. And a lot of, like I said, if they're old and sick, do the right thing for the patient. Don't subject them to a total if you think they can handle a segmental colectomy. And if they're young, they have a lot of life left ahead of them, maybe go down that total route because you don't want them getting another colon cancer that you maybe can't treat down the road. If it's a woman and if they have an MLH1 mutation and they're done having kids, most guidelines would say also do a concomitant hysterectomy and salpingo-oophorectomy. And why is that, Olivia? Yeah. So endometrial cancer is the second leading cause of death in women with Lynch syndrome. So they're done having kids. You know they have Lynch syndrome. You're going in there for another reason, take out the uterus and ovaries. And then what about all the other ones? Because they get gastric cancer, they get all the other things. Do we do prophylactic anything on them? No, we don't. Actually, it depends a lot on their family history. So if they come from a Lynch family with a strong history of gastric cancer, that kind of increases your surveillance for them. And if they get gastric polyps, then you start talking about prophylactic hysterectomy. Those are rare patients. So Lynch syndrome also affects how we treat patients' cancer after the cancer comes out, particularly with chemotherapy, particularly with early stage cancer and metastatic cancer. The middle stages is still a giant black box for us. We don't quite understand what's going on. But this is same paper where they looked at tumor mutation profiles, where they looked at about 2,000 patients with stage 2 cancer that got randomized chemo versus observation after surgery. The people with MMR deficient tumors had about a third of the recurrence rate at 10 years relative to people with MMR proficient tumors. And so what do you think, Justin, your bang for your buck in chemotherapy would be in that group? Yeah, in the deficient group. Yeah. No, your head's in the right place, right? It's really hard to improve on 90% at 10 years, which is kind of a giant theme in all of cancer, not just colon cancer. So they, for whatever reason, the MMR deficient tumors, we think it's immune related, not entirely sure, had a lower recurrence rate at 10 years relative to people with intact mismatch repair. And when they were given chemo, we saw the same thing out. In stage 2 disease, we thought maybe 5-FU was hurting the patients. So people with MMR deficient tumors, stage 2 disease only, they got 5-FU, had about double the recurrence. There's people that got nothing at all. There's a lot of postulated reasons why that may be. We think the 5-FU may be limiting the immune response to these tumors, which we know is important. And so it may have been knocking out the body's natural anti-cancer defense mechanism to prevent recurrence by giving them chemo. The problem is in stage 3, it didn't matter at all. So I think whatever we're thinking about is overly simplified, unfortunately. So brass tacks in people with mismatch repair deficient tumors, stage 2, chemo not helpful. Stage 3, chemo, because we can't figure out which of those patients are going to be better served without. Okay, so there's that. But in the metastatic setting, totally different thing. On the right, so if you see any study named Checkmate, it's studying the drug nivolumab and plus minus ipilimumab. So these all came out after 2000, where every trial had a really cool name. So it got Keynote, Checkmate, Quasar, all that stuff. We see Checkmate, though, that's checkpoint inhibitor. So that's an immune therapy trial. Keynote means Keytruda, which is an immune therapy as well. So you see any of those two things, and there's tons of them out there. Like this is the 177 study, this is the 142 study. They're studying these for every cancer type, basically. But if you see those two things, it's an immune therapy thing. So in Checkmate 142, they gave metastatic colorectal cancer patients ipilimumab and nivolumab. And in Keynote, they gave them pembrolizumab. The Keynote on the right side is kind of our gold standard study right now because they were randomized to immune therapy versus chemotherapy. On the left side, it was just, they were just given straight up immune therapy without a comparator group. The important thing though, is when you look at their 2-year survival, is metastatic colon cancer, 2-year survival is still 60 to 70% for historical context. Annalise, do you know what the nationwide, the 2-year survival for metastatic colorectal cancer should be? Higher or lower than that? Lower, yeah. Median survival, so half of our patients are still dead, all comers, by about 24 months in this country. So their single agent data right here are still better than what we're getting historical controls, and historical controls are people treated with chemo. On the Keynote study, they randomized a bunch of patients with metastatic colorectal cancer to pembrolizumab or chemo. And what they found was something really interesting. So one, you see that the survival curves cross. So we're already knowing like it's violating proportional hazards. And so is this really like an apples to apples comparison? But what you want to look at is the tails of both those curves. So the green curve is pembrolizumab and the blackish curve is chemotherapy. See how the green curve kind of levels out after about a year? And the black curve just kind of keeps going down. So the black curve is very kind of standard metastatic colorectal cancer survival, whereas the pembrolizumab arm, there's something really funky going on there. And this is when they looked into it and they saw, well, maybe it's because there's a different response profile for pembrolizumab. Yes, there is. On the left side of the screen is pembrolizumab response profile. On the right side is chemotherapy. What I want to draw your attention to is the top two sections, the little hashtag, the little hashed line, and then the line right below it. So these are people that responded. So complete response, that's pretty cool. I don't know how they actually measured. Well, they did this with RECIST, so they just take CT scans, they measure how big and small the tumors shrink on the scan. So these are people that responded. So clearly more responding to chemotherapy, right? These are the people who grew on therapy. Also more down here. So what was weird about the pembro, at least to me, is that very few patients, the tumor stayed the same. And like by stay the same, it fluctuates within a certain range on their CT scans of size. On chemotherapy, this is a pretty standard chemo thing. Like some of them respond, most of them stay the same, some of them grow. On pembro, they either shrink or they grow. And very few stay the same. Now you're gonna get a Nobel Prize if you can figure out how to figure out which patients are gonna be here and here, right? I don't know. Maybe Dr. Clifton knows, I don't know. Okay, and then trivia tables. So that's what I got. Like I said, from the cancer standpoint, I am not a colorectal surgeon, so I cannot discuss the nuance of these operations the same that our colorectal surgeons can. But we can talk about the cancer side of it. And just know that MSI high has changed our landscape for treating people with cancer. And when you're thinking about someone with a cancer syndrome, one, what the cancer is going to kill them. Two, what else could kill them down the road, even if you take care of the colon. And if you know about it beforehand, how is that going to change your management on the back end? That's all I got. We have, oh good, 10 minutes. Questions from the field. Whiz bang. And like I said, I'll make the tables available for everybody for your ABSITE study.